Ladies and gentlemen, no greater courtesy could be extended to a generous and much-loved colleague than your attendance at today's valedictory lecture by Professor Wallace Ironside. He is an esteemed colleague of all of us in the Faculty of Medicine and a man that we respect greatly. Well, you are most welcome. We are delighted that you've come from many parts of Australia to this occasion and that you've participated in an afternoon that has been, I believe, full of interest. But it is of special interest in that we're going to have a valedictory address from the Foundation Professor of Psychological Medicine in the university to which we belong. We are delighted, Vera, we're delighted that Mrs. Ironside is here because in a way we're paying tribute. We always pay court to her, but we're paying tribute to her today. She is not aged a day since she appeared here first in 1969, although Wallace has moved along that pathway a little more. Professor Ironside is a graduate of Aberdeen University of 1940. He took time off to do an internship and then immediately became medical advisor in mountain warfare to the Central Mediterranean Forces. Now, this experience has stood him in good stead over the succeeding years. And we make it a requirement of professorial appointment at Monash University to have experience of that sort. Without it, no professor survives. Monash was established not to provide a haven, but to indulge in that sort of confrontation that leads to excellence. And there's no doubt that every chairman, every foundation professor had to do battle, and it was right that he should do so. But there has emerged over the past 22 years a faculty which I certainly am proud to belong to, and I believe Professor Ironside also. Each of our colleagues, I think, would feel that there have been advantages in this battling process that everyone indulges in, everyone who is seeking excellence. And that excellence has been represented also in the Department of Psychological Medicine, which has been headed in such a distinguished way by Professor Wallace Ironside. He came to Monash with not a little experience about being a foundation professor, because he'd been foundation professor in the best medical school in New Zealand at that time, which was the University of Otago. It still is the best university medical school in New Zealand because I come from it. But Professor Ironside joined us in 1969 at a time when the other clinical departments of medicine and surgery, obstetrics and gynecology and pediatrics had been established. In retrospect, and indeed at the time, it was felt that we had delayed too long in this development, but the funding constraints which applied at that time, as they do now, made it impossible to enable a very important clinical department to be established. Now, I am not a clinician by postgraduate training, and a degree of medicine has no meaning because it happened light years ago for me. I therefore lack understanding of clinical problems. But nevertheless, as the first appointment in the Faculty of Medicine at Monash, I've become something of the recorder of events. And I noted with interest the way in which the Department of Psychological Medicine established itself in the university and in the medical school. Marvelous things have been done. Marvelous colleagues outside the department have gathered and joined members of the department in promoting the interests of psychological medicine in all of its forms. The department has involved itself in teaching in every year of the medical course. The influence of the department, therefore, has been very considerable. And from my vantage point as an unofficial faculty observer, it has been interesting to me to see the way in which the presence of this department and the thoughts and ideas and philosophies espoused and presented by Professor Ironside, the way those notions have been presented and accepted by Professor Ironside's colleagues elsewhere in the university, to the extent that the Faculty of Medicine has a perception, I believe, of the objectives of psychological medicine and psychiatry in a way that perhaps few other medical schools anywhere in the world have. And I pay my personal tribute to a colleague for whom I have the utmost respect. You've not come to listen to me, but I've tried to convey in a few words the feeling, the views of Wallace's colleagues, the affection they have for him, the respect that they have for him. And for us, this is something of a moment of sadness, because he gives up his responsibilities at the end of this year, but we would like you to know that we hold him in very high esteem, and we look forward very much indeed to hearing his address, although we regret that it is a valedictory one. Professor Ironside.
I heard about this valedictory address quite some months ago, and since then it really has preoccupied me. I have suffered a severe period of obsessional rumination about it, and all sorts of procrastinations. And very recently I decided that I would speak off the cuff. I wouldn't write a long paper and read it out to you. That it would be preferable just to meander on a little bit here and there. On the other hand, certain things got the upper hand of me, and I felt that if I allowed my unconscious to have untrammeled sway, well, you'd all be going out the door there whilst I was still talking, and I wouldn't realize it. So I felt that it was necessary for me to have some sort of restrictions. And what I have done is to take just a few cards to help me on the way, and to make sure that I don't overstep the 1.5 hour mark. And you'll know how I'm going when you see I'm coming to the bottom one. I'm using the technique that most people use now. They either have slides or transparencies, but for a valedictory address I felt it would be better not to use those. I've also got something here which I'll explain to you later, but it's a black rod, as you can see. Now, last night, my friends and my colleagues in the Department of Psychological Medicine decided that they'd better set me up proper for today, and we all went out for dinner last night, Vera and myself and the others, and they were there, and I want to mention their names, as I shall be doing in the next few minutes, the names of various people, because of my feelings for them. John Tiller, Graham Smith, David Kopolov, Ellen Berra, Jenny Ponsford, who has just left after a relatively short stay, Jay Jethwa, Suan Opas-Konkul, Peter Kinchington, David Martian, who worked in the department for some years and is now working at the Queen Victoria, and their partners. And we had a great time. So that when I got home, my obsessional rumination had been quieted for a while, except that it started up at 5 a.m. this morning. So you're seeing someone who is fairly worn out, to put it politely. But I should like to mention also that there is in the department, there's Nola Biddle, who was unable to come along because she's not well. And I would like to mention to those who have worked in the department over the 13 and a half years that it's been functioning. Lewis Miles, whom I'm delighted is here today, and Mal Kidson. There's Andrew Hornblow from New Zealand, the one and only PhD in psychological medicine, Paul Martin, who is now in Western Australia, Warwick Ashley, who is in Hobart, and Ian Shaw, and Jamie McCarthy, who were the technicians before Suwan took over the job. And I would like to also mention some names, and in doing so, I may say, just because they come to me in trying to collect my ideas, not because of any great preference, not because of any sort of favoritism or anything like that, but there are so many who have helped over the years. I must mention Bill Orchard, whom I first met many years ago in Rochester, and where we struck up a friendship, and George Lipton, who was here earlier this afternoon. I don't see him around at the moment. There he is. There's George. George and Bill were key figures in the Psychiatric Treatment Center when I arrived here. Roger Buckle and Sandra Hacker, who trained with us and in a meteoric career has now become the chairman of the Psychiatric Treatment Center here at Prince Henry's. The late Graham King, who was a delightful person and who contributed so much to what was going on in the department in terms of ideas and innovative thinking. And there have been many others who have participated in the teaching programs that have had to be organized around the town. Prince Henry's Hospital Psychiatric Treatment Center has been a most congenial and stimulating place in which to work. The Department of Psychological Medicine is part of that setup. We have had our confrontations, we have had our battles, there have been hostilities, but there has been immense friendship and underlying trust, and I think that this kind of mixture of feelings and ideas that go on certainly creates an atmosphere of thinking about problems and trying to come to innovative solutions. There's been Prince Henry's Hospital itself. Of all the teaching hospitals I've been in, this is the best one. I can say that without any hesitation. It's been a fine place to work. The relationships with staff have been so excellent. I would like to mention, outside the Department of Psychological Medicine, some of my academic colleagues, because they played a particular part for me in the trying to come to some decisions about psychological medicine at Monash. I remember with great fondness and affection Brian Hudson, who was professor of medicine here. Now, what a man he is, and he was full of the joie de vivre and challenge and all sorts of ideas, and I found him most invigorating. And then there was the professor of surgery here, Jim Watts, who did help in very significant fashion in the teaching of liaison medicine in the surgical wards over which he had control. And indeed, John Lanyon, one of the registrars at the time who was here, reached the stage under the tutelage of Jim Watts of having something like half the teaching time in surgical tutorials, which is quite something and is quite unique. Then I should mention that there have been visiting and full-time staff here whose company and help I've enjoyed, but I want to mention very much Bob Atkins, whose approach to end-stage renal failure and renal disease generally has taken the psychological aspects very much into account. And I'm glad too that Henry Hillman has come along. Where's Henry? I said hello to him. Oh, there he is. Oh, that's why I didn't see you. But Henry, very early on, gave me a great deal of help, and it's a pleasure that he is our current clinical dean in the hospital here. And I do also remember Joe Frieden, who in his capacity as clinical dean was very helpful indeed. A hospital like this has a board of management, and I think that at times those of us who are clinicians and academics get rather hot under the collar about the board of management. But once more may I say that having worked with boards of management and in boards of management in quite a number of hospitals, I have found the board of management here at Prince Henry's excellent and helpful. Lindsay White, the current chairman, current president, has put up with a great deal of pressure from psychological medicine in one way or another, and I think that looking back on it, his contributions will prove to be very significant for psychological medicine in the hospital. In the medical faculty itself, there was Rod Andrew, who was here when I arrived, and who guided psychological medicine in the early days, and you have just heard from Graham Schofield, whom I knew in New Zealand, and that we indeed were members of a small group of neurologists, of physiologists, of anatomists. When I put this in the plural, there were only one each, and a neurosurgeon and myself, and we used to meet regularly and think about various problems, and that was very, very important indeed for me to grasp viewpoints from outside my own discipline. Tony Linnane has been very important for PsychMed at Monash. It was he who provided me with all sorts of interesting administrative details that I had no idea about. But not only that, he knew them so well that he knew all the loopholes. And as a consequence of this, we were able to push through the proposals for behavioral sciences and subsequently for the membership in psychological medicine. And I don't know if Tony is here, but I do pay special tribute to him. In the early days, Hugh Dudley was a particularly significant, stimulating, extraordinarily creative person whom I greatly enjoyed. And there have been many others in the medical faculty who have contributed so much. Well, if I get these mixed up, you're really in for it. Now, during all these interactions with the many people that we all become involved with in doing our work and endeavoring to carry it out, there have been a great, shall I put it, predominance of agreements. There have been failures of understanding. There have been committee meetings that seem to have gone on interminably and no results emerging. Though in the long run, something does usually emerge, which is a good compromise. And I'm very, very conscious today that in this valedictory address that I am, in fact, saying a farewell to all of you, but it's a farewell which consists of a saying. After all, valet means farewell, and dictio means a saying. So I'm saying it. That doesn't necessarily mean to say, so help you, that I'm going. And that's an important issue. Attempting to work through what I might say today did highlight for me the vagaries of memory. And I do hope that those whom I may not have mentioned can attribute that to my neuronal fallout, which at this age of 65 has become quite substantial. I should tell you that in the audience there is an esteemed friend, Dr. Janet Irwin, who was present at the inaugural address that I gave at Otago University. And after everyone heard that, it was decided that they wouldn't have any more inaugural addresses at that university. And it may well be the case that after this valedictory address, I shall have... I won't say any more. Today's symposium on the teaching of psychological medicine was arranged with great energy and with quiet competence by John Tiller. And I'd like to thank him for that. Thank you, John. It's been good. And I must also mention Mrs. Jessica Barr Taylor, my secretary, because she played a tremendous role in doing all the spade work that's involved. And I must say that I very greatly enjoyed the contributions at the symposium earlier this afternoon. I thank the speakers for having given off their wisdom, and I thank you for the tributes that you gave me. The teaching of psychological medicine, and this is something that Graham Schofield has already referred to, faced a particular challenge when I came to Monash in 1969, and that was that the curriculum was already there, not quite in concrete, but at times I felt that it was, and that all spaces in the curriculum seemed to have been filled. So that to begin with there was a struggle, and as I've come to recognize, it is part of the Monash ethos that all the time there should be a struggle. And I think that that's a rather important thing to remember. Indeed, just to make sure that I got this absolutely correct, I must tell you that the only sense that is common in the long run is the sense of change, and we all instinctively avoid it. Now, pharmacology is taking up the slack of this at the moment, and I wish Alan Borer well in his struggles to make sure that his discipline gets a good slice of the cake. Psychological medicine is the application to clinical practice, as I understand it, of the psychology of human behavior. And listen to it, here is the horrid word, and the biopsychosocial approach. Because, like it or not, this word and what it stands for is creeping into not only the psych literature, but you're finding it in medicine and you're finding it all over the place. In fact, it touches on systems theory. And this is, of course, very important in the kind of work that we do. The trouble is that in discussing systems theory, I've come to the conclusion that I'm one of the few people who understands what it means. That puts me at a definite advantage, but at a disadvantage too when it comes to communication with others about what I'm trying to get at. And it has resulted, I may say, here in Monash, at least to getting us a slice of the cake in the preclinical years with the behavioral sciences, because it seems to be accepted, perhaps not with great enthusiasm at the moment, that if you're going to do psychological medicine, you should have some basic training in normal behavior early on. I should tell you a story of the recent tribulations of a student at the final examinations who presented, having examined beautifully and presented very clearly and succinctly, the condition of a patient who was suffering from a melanoma which had resulted in a pathological fracture, and her arm was up in a sling because during the course of the treatment of this fracture there had been damage done to the median nerve, and she had great pain over the distribution of the median nerve and couldn't use her arm at all. Now, unfortunately for the student, I was there in the examination team, and I listened with pleasure to his statement of his findings, but as he came to the close of them, he hadn't mentioned pain, nor had he mentioned this woman's disability. That is, what she could not do and what she was finding great trouble in accepting, such as she couldn't cut the bread, she couldn't cook anymore, she couldn't take off her undies without the help of her husband, and she found this very degrading. And she was preoccupied by her pain and described how it was that she was on an analgesic mixture, the fine Brompton Hospital mixture, and that she had found, above all, that having 6 tablets of tryptanol at night allowed her to get off to sleep. And she was telling us something very, very special about antidepressants and the relationship to pain. And when I took this up with the student, unfortunately he was unable to carry through on these supreme management problems and for the patient, the problems. And I couldn't help feeling that it might be the case that if he had adopted a biopsychosocial approach, he might not have missed out on, even in the examination time, on what was happening. After all, I'd seen the patient beforehand, and in a matter of some 6 or 7 minutes, he had spilled out all this story that I just told you. And that reminds me also of one of the fringe medicine people. And it goes something like this. There was a faith healer of Deal who said, although pain isn't real, if I sit on a pin and it punctures my skin, I dislike what I fancy I feel. Teaching was of primary importance to psychological medicine when we started here. There was a program to get going. It was very much my ambition that this should spread throughout the 6 years of the course, and that required a substantial effort. There were only 3 of us to begin with in the first year here, Lewis Miles, Mal Kidson, and myself, and so we were spread very, very thin indeed. And it makes me wonder just why it was that we took up this teaching role. Some years ago in New Zealand, after the Department of Psychological Medicine was established there and getting some publicity, I received an abusive letter from someone whom I thought was quite disturbed, pointing out that wasn't it terrible what the psychiatrists were doing these days. And after a long stream of abuse said, and the trouble with you all is that your parents have been teachers. Now, in paranoid ideas, those of us who are experienced know there's always a germ of truth somewhere. Now, well, I won't tell you all about this, but at any rate, I thought I'd better conduct a rapid research on the 8 people in the Department of Psychological Medicine there to see if they had a parent or parents who were teachers. They all had. I don't know what this means, but it does mean that as far as I'm concerned, teaching took primary importance when I arrived at Monash, and that had to get on the way before other things started. Research had, in those circumstances, a rather second priority and lagged behind, but I think it is enormously gratifying that during the past 6 years things have changed a great deal, and with results which are now, after all this length of time, coming on stream. I'm particularly indebted to John Tiller for the immense amount of work he has done in research and taking up a difficult area which is now beginning to present us with some very challenging and some very interesting and I think in some respects quite revolutionary results. And then latterly, Graham Smith, who was in anatomy, decided to throw in his lot with psychological medicine and took with him a handsome grant to psychological medicine and was able to occupy the biochemical laboratory that had been lying empty all these years. And his work in the neurosciences is going ahead with great speed and also producing some very fascinating and interesting results. Latterly also, very recently, Ellen Berra has joined and has got research work undergo, and Ken Johns, who had to bear the brunt of looking after psychological medicine for many years, is also getting his chance to get stuck into research. So on the research side, I think that here at Monash Psychological Medicine, things are going reasonably well. On the clinical side, it has been my experience throughout my career to work in the general medical and surgical and other wards of a teaching hospital. And it's inevitable in these circumstances that one gets caught up in liaison service. And I know, this is a belief that I have, that if psychiatry loses touch with the practice of medicine, then there are bad things will happen to it. I'm rather disappointed in recent visits to the UK to find, for example, that the question of liaison service is now very much in the background. Professor Cairns-Aiken from Edinburgh, who was here in September as our guest speaker, was at one time in the Royal Infirmary in Edinburgh, not so many years ago. He was the only liaison psychiatrist for 2,000 beds. That's astonishing to me when one knows that at least 50% of patients in general hospitals have psychological problems of quite important significance for their overall management and care. The kind of problem that does help us along is to be found in this simple statement of a patient. The kind of patient whom we all come up against in the wards, and he says, I am 29, single. I neither drink nor smoke. But I do not seem to be able to overcome the sex impulse. Is this due to catarrh? And will a diet of vegetables and salads help to abate it? Now, how does one get to first base with such a patient? That is the challenge for psychological medicine and liaison psychiatry. I now go more on to personal matters, and I thought that I would say a few words about how it was, as I see it, and I'm sure this is grossly distorted, how it was that I came into psychiatry as a career. Well, I've mentioned my mother, a very important person in my life and a teacher whom I greatly revered, and undoubtedly she played one of those important background roles which so much direct one into certain decision grooves. I do remember also with great fondness Miss Gary, my teacher of Latin and ancient Greek at school. Now, it was rumored that Miss Gary was frightened of mice, and here I come to tell you about my first experiment in behavioral psychology. But no one had ever seen her act when a mouse came into the room. Well, I managed to get a hold of a squash ball and saved it up for the right moment. And during an earnest discourse on some Greek, probably Xenophon or something like that, I happened to have chosen the back of the classroom, and down the aisle I gently threw this black squash ball. And as soon as she caught sight of it out of the corner of her eye, she leapt up onto a chair with a scream and pulled up her skirts. And I was satisfied that there are certain very interesting things that can happen, and I proved to myself that indeed a little stimulus like that can have quite profound effects on the behavior of people, in spite of a group of students looking on, all of whom, of course, had to laugh. Well, that was the last time that I received the tawse. Now, those of you who don't know, that Scottish word means the strap, which means the belt. But as Miss Gary was about that size and didn't like chastising her pupils, I may say that I don't remember any pain that I may have received then. I also fell in love about that time with Miss Young, my chemistry teacher, with dramatic improvement in my chemistry work. And perhaps because of her, I've always been interested in chemical processes of one kind or another. I'd like to think that this has kept me on the scientific narrow path. Those times when I find myself wandering into the blue yonder when one comes to thinking of the psyche. Some books, I think, have influences on her. I remember reading Naomi Mitchison's compendium on knowledge, but the book that struck me hard when I was at school and left a terribly deep impression on me was H.G. Wells's, Julian Huxley's, and G.P. Wells's book, The Science of Life. Some of you who are of my generation may remember it. Because of my travels, I used to get rid of all my books, and I wondered why I got rid of The Science of Life, and some years ago in London attended a rare book sale where a copy was available. It wasn't a very good copy, but I found that it was far, far beyond my pocket to purchase it, so I just had to leave it. In medical school, because in the science of life, Jung and Freud and others were mentioned, when I got to medical school, I thought I'd better dip into these things, and I looked at Jung's The Psychology of the Unconscious, and that put me off Jung for the rest of my life. I found that I was reading the Bible, I was reading various Oxford books of reference and all the rest of it to try and understand what he was getting at because of the great number of footnotes, but I didn't understand very much. Now, it was about the time that I was in my 4th year when the Penguin book came on stream, and for sixpence, which was a very small sum of money, even in those days, for sixpence you could buy great books. And one of the first books that came out was Freud's The Psychopathology of Everyday Life. And I read this with great pleasure and joy, and I thought, well, that's the man for me. He makes sense. And the kind of sense he makes, you know, he takes up the parapraxes, these are the slips of the tongue, the slips of the memory, and these kinds of issues. And I'm a great one for doing that, I know myself. But he brings these up and hints at the possible meanings of those, though he does, of course, hasten to state in his book that you can't get the meanings unless you're prepared to talk it through with a patient. But here's a very good example. Now, this is an ABC national news announcement on Tuesday, the 2nd of November. That was the Melbourne Cup Day at 7 p.m. on the radio. And it goes as follows. The Prime Minister, Mr. Fraser, has called off all appointments for the rest of the week while he recovers from a painful sciatic condition. A spokesman in Canberra for the Prime Minister said, Mr. Fraser had spent the day resting in a Melbourne hospital and that it would be at least another week before the Prime Minister was out of office. I listened with bated breath to the 9 o'clock news to find that it had been corrected. But it's there on record, and that's a classical parapraxis, the slip of the tongue, and what it means for Fraser and those who look after him, I leave you to guess. Now, in medical school itself, I had some fascinating experiences. There was Papa Henry and hypnosis, and it was there that I was taught that I mustn't believe what I think I see. Now, Papa Henry was a revered physician, and he had a feeling for matter psychological, and it was part of the tradition of going through his ward that at some stage he would demonstrate hypnosis to us. And sure enough, the time came for my group and myself to witness Papa with his patient. And the patient was on a couch, and Papa Henry went through the usual motions, the ceremonies that are associated with creating an hypnotic trance. And the patient slowly went off and came to and eventually went into a deep trance. And Papa Henry turned around and said, well, there it is. He won't remember anything when he comes to, and he'll do all sorts of things for you, and demonstrated certain things that this patient would do whilst under trance. Now, whilst Papa Henry was talking all about this, he happened to turn his back to the patient to talk to some of the group that was aside here. I was looking at the patient, and he gave me a broad wink. Now, that was a single trial learning for me, and created an impression that I shall never forget. More on to the sort of psychosomatic or the psychophysiological side. I went through medical school with a close friend. We'd gone through school together, secondary school together, and we were close friends. And I remember the names of these teachers very well. It was Tommy Morgan from what in those days would have been called materia medica, not pharmacology. And he was demonstrating in the ward how to do a lumbar puncture. And he was very skilled at this and all the rest of it. My friend and I, we were watching very carefully. And at the end of explaining what he was going to do, Tommy Morgan turned to us. There were only a small handful of 3 or 4. And he said, you know, it's a strange thing, but whenever I do this for the first time for medical students who've not seen it before, someone's bound to faint. So he prepared this huge needle, it seemed about that long and that wide, And he fiddled around and he got the surface markings and he stuck the needle in, and there was a great crash. And that was my friend, flat out on the floor. And Tommy paid no attention. He just went on with his lumbar puncture, and my friend John came to absolutely astonished where he was, on the floor looking up. He's become an eminent surgeon since then. But that demonstrated to me that things that people say can have quite profound effects, and that was certainly one of them. Also at medical school, and this touches on the subject of something that is close to all of us in more ways than one, and this was in the gynecology run, and I was allocated an 86-year-old woman who had a prolapse of the uterus to examine. And I went about it as best as I could go. And after getting the initial history and conducting the examination, she began to talk to me. And she said, well, whilst she was worried very much about her condition, her pelvic condition, there was something else that worried her a great deal more. What was going to happen to her husband, who was 90? And it struck me that this was a strange thing to worry about, so I pursued the matter a little more, and I asked her what it was that she was worrying about. Well, she said, we won't be able to have intercourse. And I thought, well, this is getting a bit too much for me, but she was keen to tell the story. It's not only that she felt that they would not be able to have intercourse after her operation. She also felt that he would be missing out on things while she was in hospital, and what could he do about it? And that restored my faith in human beings very much. At medical school, I came under the influence of Douglas McCalman, the first lecturer in psychopathology in Britain, and I attended his small series of optional lectures at 5 p.m. and was greatly impressed by him. And I'll mention him shortly. I did, Graham, I'm sorry, but there's one little mistake, that before I went into the Army, I did have a spell in the casualty department of my hospital. Just as well if I was going into the Army, and particularly that job that you spoke about. But in casualty, of course, there are all sorts of things that one comes up against, crisis situations, though that wasn't used in those days. And there was an emergency mission to hospital, to the casualty department early one morning, a soldier who'd come up from London suffering from the most acute abdominal pain. He was writhing about, he didn't know what to do, he was in one of the cubicles, and it was my turn to see him, and I examined him carefully and found that I could elicit no clinical signs of any significance whatsoever. I palpated and couldn't feel any lumps, and there seemed to be no tenderness there, and so I did the next proper thing, and that is go further down towards the pelvis. And I happened to put my fingers gently on the lower part of his inguinal canal on the right side, and he winced. And I did it on the left side and pressed a little harder, and he almost screamed. Certainly he leapt, and I thought, this is a strange thing. But the fact was that in that time and that kind of group that I grew up with, there was a syndrome called lover's balls. That's how we called it. And this was a condition that supervened when there was severe repression of the sex impulse in close proximity to an adored woman or girlfriend. And as it turned out, he had just been married in London, had come up to Aberdeen on the night train, which was very crowded, and he couldn't do anything about his feelings. And here was another superb example of a psychosomatic reaction, pain having to do with biological urges. And that left a deep impression on me. During my Army service, I was impressed by the numbers of psychiatric casualties. The British Army had, at the end of the war, 50% of its total casualties were psychiatric casualties, which is really quite striking. And I came across many examples of people who were anxious and frightened and didn't know what to do about themselves, etc. And they were usually shifted off home. This was not only in the combat zones, but it happened to be also in other echelons. And as the war was coming to an end and I knew very little about psychiatry, I asked if I could be transferred to a psychiatric training center, and that did indeed happen. And I went to a marvelous place, a Bourbon palace on the Sorrento Peninsula called Quisisana, where there is health. And what an idyllic place to start psychological medicine. The gardens had camellias, which have always been specially linked in my mind ever since with my discipline. And these were in the Italian style, done like great big balls on a central stem. And come the winter, the late winter, they started to bloom, and I thought this was quite miraculous. But above all, there were a group of young Turks. That's the only way to describe them. The more, when I say senior staff, my goodness me, they seem like children when I think back in it now. They were only in their early 30s. And there was a great system there of talking and discussion, and we started first thing in the morning and went right on through dinner and right on into night, and I just loved that. And it had a profound influence on me. I got hooked on psychiatry there. And I decided that it was obviously a discipline of the future. There was something a little bit outrageous about it. You were bucking the system, because psychiatry certainly wasn't popular at that stage, and it's not all that popular now. But it seemed to me to be intellectually challenging, certainly emotionally rewarding. There's a kind of voyeuristic aspect of looking into the psyche and trying to understand what's going on there. And then come the end of the war, and Anoran Bevan started the health service, and suddenly he demanded that all the doctors that could possibly come out of the army and get into hospital positions. And it was in that setting that I once more came up with Douglas McCalman, because I wrote to him and said, look, I'm coming out of the army, can I have a position with you at the Royal Aberdeen Infirmary? That's the teaching hospital of my alma mater. And he was very glad to accept me. Douglas McCalman was a child psychiatrist. He established the child guidance movement in London after a Commonwealth fellowship in the USA, and it was he who introduced me to all the aspects of child development, but particularly the developmental side, which I thought is always tremendously important. It's very important for our students to know this about the normal development of the child in the psychosocial aspect. I also came up against therapeutic abortion. Interestingly enough, that was mentioned this afternoon as an example of the difficulties that face those who practice and want to teach psychiatry. And I had my encounters there with that formidable man, Sir Dougal Baird, who is the professor of gynecology and obstetrics at Aberdeen University. And of course he always won out, but nevertheless it did very much impress on me that there are very important issues which are not to be answered purely by clinical attention. I went on to the Crichton Royal, and there I met Willy Meyer Gross, a most marvelous, delightful, erudite, extraordinarily clever man, and I fell under his spell. He ran the insulin therapy unit there, the insulin shock therapy unit, and I spent many mornings with him there and listened to his philosophy and his teaching and all kinds of things that he could talk about. Indeed, Willy Meyer Gross was a great help to me in the first systematic research that I conducted, and which enabled me to get my MD. But Willy Meyer Gross did illustrate what all of us unfortunately suffer from. There are certain areas that we don't move into. As you know, it was in 1954 or 55 that a paper by Harold Bourne, who came to New Zealand and worked with me for some years, published on insulin shock therapy, suggesting and giving some good evidence that perhaps the results from it were no more than one might expect from a placebo reaction. And subsequently, the Maudsley group took this up and did a definitive research, and 2 or 3 years later published their findings that suggested that insulin shock therapy was in and of itself was a little advantage. And I know that Willy Meyer Gross was very much taken aback by this, and it was something that he had to get used to. But during my work with him in his unit, he would speak at great length about what he did with patients after the shock was over. You'd think nothing of spending 3 or 4 hours with patients talking about their problems, running spontaneous groups, doing individual therapy. But that side of it he put away. It wasn't important for the work that he was doing. But we all have those blindnesses, and unfortunately, sometimes they can trip us up, and in Willy's case, they did so then. Following that, after a spell in Leeds, and that was with Douglas McCalman, where I became his senior lecturer. I'll skate over that. I went to New Zealand, and their liaison psychiatry just had to be. I was the only psychiatrist in the hospital, and I didn't have anyone to help me. It was very much a one-man, my own show to begin with. And Douglas McCalman came out to Australia around about that time on a tour. Some of the older members of the college may very well remember this. And he came to stay with us in New Zealand, and I went off, whilst he was still there, to a meeting in Canberra. And it's just a great pleasure and joy that Frank Graham is here, because he and I gave papers at the same section in that particular scientific meeting. And it's a pleasure also that Ian Martin, who was a relatively young secretary at that time, has come here this afternoon. I'm just delighted you're here, Ian. It's good to see you. I remember Guy Springthorpe because he introduced me to the delicacies and the delights of Australian wine and French brandy, and I won't forget that. Douglas McCalman was in very impaired health, very impaired indeed. And I must say that I remember this because of this occasion. It was indeed a farewell visit, because I never saw Douglas McCalman again after that. And I was very touched that amongst his belongings there was, after he died, there was something for me. And that's why I brought this instrument along. Some of you may immediately recognize this as a priceless antique object. It indeed is an ebony ruler that would be used in the old days before there was any office automation at all on those tall sloping desks, and it rolled down whilst the copper plate writer did his beautiful writing. And it seemed to me symbolic of all sorts of things, but particularly of that feeling that some people have about psychiatrists, that they have magical powers, but we know only too well how poorly off we are for such things. In New Zealand, I worked closely with Horace Smirk and his work in hypertension, and saw quite a number of patients with him. And whilst Horace would give no credence to psychological factors in hypertension, he certainly did give credence to problems of compliance. And I had the pleasure there working with Keith MacLeod, neurologist, and Richard Robinson. And I must tell you, Richard Robinson was the neurosurgeon. I must tell you here a very brief story about a patient who was important to me because of what she told and what she taught. This patient had a severe obsessional neurosis. Everything had been tried. I was asked to see her to confirm that perhaps a leucotomy or a frontal lobe lobotomy might be something that would help her. She'd been ill for many years, quite intractable and completely crippled. And so after a great deal of discussion with my colleagues, and Richard Robinson came on this, he agreed to do this. He did an open lobotomy, and I scrubbed up and watched what he did, and was very impressed by how he reached the necessary area. Well, there was a very dramatic recovery, this patient. She improved enormously. She was out of hospital within 3 months and into a rehabilitation scheme. At the end of 6 months, symptoms began to return. At the end of a year, they had all returned in full strength. And the question was what more could be done. And there really wasn't very much more to be done. I saw her over a period of several years, and there came the stage when her symptoms reached a stage of great intensity and pain. Her brother, whom she hadn't seen for many, many years, an eminent physician, was returning to New Zealand, and how to face up to him was something just she couldn't tolerate. At any rate, there was nothing for it, but she had to face him. Now, you can look at this, it could be a flooding thing that had happened, But within 24 hours of her meeting him, she had an abatement of symptoms. Within a matter of weeks, they had virtually disappeared altogether, and within 3 months she was back at her work, in fact as a librarian. I followed up her case over a period of several years because I was quite fascinated by this outcome, and at the end of 10 years there was no signs of any return of her symptoms, though she did say to me in a jocular sort of way that she was always a very neat and tidy person, and her house certainly demonstrated that. Now, time is slipping by, and I had many other things that I wanted to say, but I think I've rambled on enough. There happen to be about another 56 cards here, and I don't want really to impose these on you, but I would like to say that there are certain things that perhaps I've learned from patients. One of them is a very important one for me, and the trouble is it takes a lot of time. Some of you may have seen these writings at the recent exhibition here down the road. And this is obviously Chinese. Don't listen with the ear, but listen with the mind. Better still, don't listen with the mind, but listen with the spirit. And that's Chinese philosopher Zhuangzi of the 3rd century A.D. And then there's another one which I thought was rather appropriate, the kind of work I do. The wise deals with things through non-interference and teaches through no words, because it often astonishes me why patients get better, and for the life of me I can't understand why it does take place. Patients have been ill for many years, but I suspect that something goes on between patient and doctor once there has been rapport established that hasn't got to do with words at all. It's got to do with more subtle communications, such as the patient in Dunedin, whom I'd seen for some 3 years, who'd been ill for a long time and was making good strides. And much to my astonishment, she said to me, "Professor Ironside, you're leaving." I hadn't said a word to anyone that I was coming to Monash, and how she picked this up, I haven't a clue. But these are the kinds of things that do happen. Over the years, there have been astonishing changes in psychiatry. The drugs and associated therapies have just emptied our psychiatric hospitals. It's unbelievable the changes have taken place in the last 40 years. Refinements in shock therapy now means that electrical convulsive therapy can be given so safely and with much greater chance of good outcome because of selection of patients. I used to give camphor to patients to create an epileptic fit of the most violent nature, and that was the earliest form of convulsive therapy, and it was quite dangerous. The whole question of brain surgery has undergone review, and much, much more refined techniques are now being evolved. There's no question that the neurosciences are going to contribute tremendously to all sorts of very fascinating developments as we understand more about the way that the brain functions. I do have to mention just one person. I want to mention Paula Hyman, who was my analyst in London, and when I was there quite a number of years ago, and I've always been in the way of visiting her, and on this particular occasion it was to find that I could get no answer from her phone. And ultimately I did get a tape message to say that she was in hospital, and I visited her there after a few days, and to find a very, very sick, very, very sick old lady. She's 83. And she was unable to say very much, but the kind of experiences that I've had, particularly here in Prince Henry's and with the patients in the renal unit, I recognized almost immediately that she was suffering from what I call a terminal brain syndrome. She only came to occasionally. She did recognize me. She said certain interesting things like, "I know now why Van Gogh cut off his ear. He didn't want to hear." And she said that after she'd let off a blast at the resident doctor who'd been in to see her just a few minutes before I did. She didn't like that particular doctor, and according to her, that doctor wasn't listening. Now, Schopenhauer puts it this way, that every parting gives a foretaste of death, and every coming together again a foretaste of resurrection. And this is why even people who were indifferent to each other rejoice so much if they come together again after 20 or 30 years separation. Well, I don't agree with that. That's not been my experience. To go back to Paula, I went to see her the next day and she was in coma. The following day she was no better, and I saw her the day before I returned here last week to find that she was really very, very drowsy and on the way out, and she died the day after. So I was glad to have my chance of saying a farewell, but it wouldn't have meant the same if there'd been a 30-year separation. And now to conclude, I would like to say, I'm smiling because this is a famous, papermanship thing. I'd like to conclude. In summary, I'm going to say, I've just got another sentence and so on and so forth. But I do want to talk just very, very, very briefly about my family life. One can't be a professional and an academic and do all the things that are involved without there being a background of family life. And Vera, who is here this afternoon, has always been a great tower of strength and has always arranged things so that home has been harmonious, kept a tight rein on Karen, my daughter, who's here, and Sarah, my other daughter, who's in London, and made sure that they didn't annoy me. Makes me feel terrible when I say that, but I must have been a bit cantankerous at home at times. And they had to put up with it. I think that professors' daughters always have a rough time. They are handicapped and they are advantaged, and sometimes it's difficult to decide which is the better. And then I am also delighted that in the audience I have two grandchildren. Saul, my grandson, and Louise, my granddaughter. And they have listened very patiently through all of this and provide both Vera and me with great joy to see them growing up in Australia, a country that we love. Now this symposium is to mark my retirement. It has done me great honor and I appreciate it very, very much. A symposium too has been ended with an address which is...
And the range of disorders one might consider within a spectrum. That neurotic disorders, for example, may be considered on a spectrum with normality.
The only difference there is I tend to use the word dimensional.
Dimensional, yes.
All right. Now, are there any questions? Perhaps I could just ask you one
Yes.
other thing. Remember you were talking of exhibiting tapes to students?
Yes.
Little bits at a time.
Yes.
Is this the same tape to all the students at one time? How many?
No, we
have 200.
yes, we take our students, we take our students in groups of 8.
Yeah.
And they have the same tape. The tapes are duplicated so that a number of groups may be running at one time. And they would see the tape. The aim of the tutorial groups, particularly in the early years, is to use a non-expert tutor. So the tutor who would be taking the group at this time wouldn't be a psychiatrist, but would be someone with whom the students would be encouraged to generate the hypotheses that are relevant to seeing what this particular problem is. For example, our typical tape on depression is Mrs. Watson presents saying she's tired and she'd like a check-up and a tonic. The tape pauses there. The students are asked then to generate what could be wrong with Mrs. Watson. And very clearly it could be a medical disorder, it could be a psychological problem. That helps promote the overview of what could be wrong with Mrs. Watson, rather than, because this is a psychiatry term, saying that this must be Mrs. Watson. Mrs. Watson must have a psychiatric disorder. The interviewer in the videotape would then open up the question further by saying, to the students, what further information would you like? And the students would say, we would like to know how long it's been present and what other symptoms there are. And then the videotape unfolds to show that further bit of the interview evolving. And then the students were asked, well, what do they think now? What sorts of things would you need to do to find out further? At the end of the first session of that process, the students have a learning package which they take away, which will give them either general references to read about specific areas, or else will direct them to library resources or a bit in a textbook. Material that will help them solve this problem further. And then in the second tutorial session, this material is drawn together and their understanding of depression, presenting in this sort of way, is clarified.
Who are your tutors? And I presume they have meetings together.
Oh yes, yes. The tutors are trained, and they're trained in what's required, and they have a tutor guide with each problem which shows them the areas that would need to be opened up and encouraged and what sorts of difficulties. The students would then have access. Suppose a question came up in this general way, what do we mean by depression? And the tutor may feel that he was not competent, even though a sound general practitioner, to comment on the breadth of what's meant by depression. Then the students would have a meeting with a fixed resource person for that term or that unit, who would be a psychiatrist who would be able to discuss with them in a bigger group, perhaps the whole year or half the year. Yes.
Your year is
64. 64. Not like 200, so I recognise. I think some of these things can be taken. I mean, we have used the same sort of tape in a big group, and it's quite interesting to see.
We don't teach them all at once.
No, you don't, of course. Peter was wanting to.
I wanted to ask about
the
idea of a psychiatrist being somebody who looks at the whole patient,
yes.
especially one which I think most of us have brought up with.
Yes.
But what do you feel happens with the introduction of more and more family medicine programs? Because that seems to me, in a way, to be taking that away from psychiatric exposure. You know, that there's another department which is concerned with the holistic view of
yes.
but I'm not sure if they do it very well, but it's
yes.
certainly something I'm aware of.
Yeah. I think most people would be committed to the whole medicine approach. It's just that I think traditionally psychiatry does get cut off from it, and I think family medicine counteracts that. I don't see it as taking things away from psychiatry, because I think probably psychiatry is required to consider this at a much more sophisticated level than is usually part of the family medicine program's consideration. But it does seem to me it's been a common experience of mine that students present and they say, well, this must be depression because it's our psychiatry term. And if a person presents to casualty with certain symptoms, they expect them to be a physical disorder. Just the same as if a person presents to a psychiatric hospital with certain symptoms, they are expected to be a psychiatric disorder, and yet the evidence from the recent literature and from clinical experience is that there is this enormous overlap, which has been, I think, put aside. I think the college's requirement that people maintain their skills in general medicine is a very important one, because I think that has now cut across the feeling that perhaps psychiatrists didn't even bother to do a physical examination, that they saw it all of the mind and not of the body, unless there were clear organic elements. Thank you very much.
Well, now Professor Ross-Calusi is going to talk to us on postgraduate education, the diagnostic formulation. Do you want this thing?
Thank you. You'll observe that the speakers up till now are all from the eastern states, and therefore have said smooth things, full of panache, as they started their talks. We in the West are more simple people, and I'm actually damned if I can remember when I first met Wallace. In fact, I thought he was always there. And I do feel proud to be presenting on this occasion. I realise that Wallace is not going to disappear or go up in smoke, but there, in one sense, he will be less around, and I think that is a loss which I personally experience with some sadness. There is another problem that Izzy and I would jointly like to correct. Leslie, we are distressed to find that you think that other people think you're sometimes cynical. It's not true. My interest in formulation began really during my physician's training, and continued throughout my psychiatric training as an area that I could never resolve in my own mind. And it re-emerged within college, I think, some years ago, when the question arose as to whether the censors had an opinion as to exactly what they meant when they used the word. And it turned out that they didn't. And many of us were actually paradoxically quite pleased that we didn't. We thought that it wasn't one of those things you defined, it was one of those things that you learnt how to do. Some of the more practical people on the Board of Censors, however, believed that if you were going to examine it, then you should define it, so that people would know whether they'd done it or not. And the task I've set myself this afternoon is to look a little bit at that issue and that problem. If I could have the first transparency, Richard. The problem that I would like to address is it actually possible to devise a system of formulating cases that allows for good communication between consultant psychiatrists and also between consultant psychiatrists and other medical consultants. The reason for emphasizing the word consultant is that the postgraduate exams are said to aim at deciding that somebody has the properties of a consultant. And it seems to me that a formulation has something to do with the ways in which we communicate, and it's that theme that I will try and elaborate upon. You may ask why bother going into it. I think the first thing is that we do actually, all of us, have an obligation to train our candidates, and that training in some part has something to do with preparing them in such a way that they can be successful in the exam. And even though we often nowadays don't use the word formulation and use other words, we still actually mean formulate the case. And we have to, I think, allow our candidates some notion of how that event can occur. The other thing is that it does strike me that if we could find some good ways of communicating on both these levels, that some more sensible things might happen to our patients when they're under joint care. And my experience is that increasingly our patients are under joint care. Turning to what a formulation is, we usually, I think, mean something like bringing a case together. Not just yet. I know it's boring, Richard, but just... or we say, what is the case about? Or we isolate the issues in the case. Or we say, the problem here is. We use those kinds of phrases to carry over a notion of what we mean by the word formulation. And I think what we're implying is that it's a very special form of clinical communication. The closest I can come to characterizing it would be to say that it is the kind of interchange which occurs between consultants when one of them is handing over care of a ward to another, and he describes, if you will, this patient or this person or this family, and he brings it together in some kind of way that integrates and condenses information very quickly. What that is, that exercise, is the mirror image of what people like Barry Nurcombe talk about when they talk about decision-making in clinical practice. Because although we often take exhaustive histories or listen to exhaustive histories and examinations, we in fact begin to test hypotheses and to make decisions within seconds of the conversation starting. And most of the major decisions, I'm told, occur within about 3 or 4 minutes of beginning to hear about, if you will, our case. And I think the formulation is a reflection of that. It's what you bring together in order to convey enough information to make appropriate decisions. Now, if we accept that kind of definition, we're saying that it's a very brief conversation, perhaps no more than a few minutes, that somewhere in it it's going to contain something which summarizes some data. It'll probably have a diagnostic statement. It'll probably have something to say about etiology. It'll highlight some problems or some priorities. And it might talk a bit about progress and prognosis. Now, if it's going to do all those things, and quite often it does, then it has to be very, very selective. So, if we say that the capacity to formulate is that selective, then it is also a skill, clearly. It's a skill about being able to be selective, which leads to being able to establish priorities, which leads to management plans. Now, if we turn to the trainee's anxiety, in one sense, that kind of description could be construed as helpful, because it then puts to rest all these sort of mechanical questions that are asked, like, will I bring the case together? Do you want a psychodynamic formulation in the formulation or as well as it? And do you mean a diagnostic formulation or a summary? Because you don't really mean any of those things, and they're not relevant questions. And if he asks them, then he's clearly not ready to be a consultant. The issue is, can he bring it together in a way which is appropriately selective and which would convey the sense of the case to you if he was handing over? So in one sense, the trainee doesn't have to worry about those issues. On the other hand, he's got to be very worried because he now is faced with the problem that it's his task to learn that skill. He has to make the decisions about what he's going to select and whether he feels that an extensive dynamic statement is important or a small one, or a lot of interest in the family dimensions of it, or not much. That is difficult because it's clearly a function of experience. You can't actually judge whether you're good at bringing it together unless you follow patients over a long period of time and see whether the issues you identified were relevant. Now, the next transparency illustrates what I think are the main elements of that exercise, and they're all pretty self-evident. They usually begin with some kind of orientating statement that helps you to get a feel for the sort of person you're talking about, and that usually includes a summary and a diagnosis. And the diagnosis is a very powerful statement because it carries a huge amount of information. It carries an enormous weight of expectancy in the listener, and therefore is often concentrated upon, I fear, unnecessarily. Somewhere in the middle of a formulation there'll be some kind of attempt at a causal statement. That isn't always the case, but I think the kind of thing that the causal statement is trying to do is to say something like, why is this patient disordered in this way at this point in time? There may be some kind of problem orientation because at some point in time you have to say what the major problem is. For example, if in the exam a candidate presents a case, let's say, of someone who has paranoid schizophrenia and who was brought in by the police because he shot one of them, and the candidate lists as his major problems things like modicate and whether the diagnosis is paranoid schizophrenia or whether perhaps it's not quite that, and doesn't get round to talking about worries about homicidal behaviour, he's sort of missed the point of the case. So that somewhere in it there has to be something which gives you a feel. And finally, there may be something about management. Now, if we have the next transparency, it's a way of keeping you awake, please. What I tried to do to look at this issue was that I actually wrote some notes on 50 consecutive candidates' styles of doing things, and I tried to see what they used to try and summarize and bring things together, what sort of theories or systems that they used. And by far the most common is what I call a sort of phenomenological descriptive style. That really meant that they used fairly simple sentences, that they described and observed, and they actually, without knowing it, conveyed an enormous amount of information about all these areas without really ever labelling a thing like saying, I'm now going to talk about some behavioural issues in this case or some dynamic issues in this case. And when I actually went through it, that was very common and often combined with some kind of problem orientation, by which I mean how they went about establishing hierarchies of importance in their management. Now, I call these theories holistic theories, not because I think that any one of them explains the nature of man, but rather that they are all theoretical systems which help us to organize our thinking a bit. And it seems to me inconceivable that any one area could be irrelevant to any case that you saw. It really isn't possible to say a statement like, well, there are no biological issues in this case, or there are no dynamic issues in this case. Perhaps an even more obvious one is that there are no developmental issues in this case. I mean, it's kind of like, you can't actually have a case where those information is not relevant and probably useful if you care to use it. So that I think, but none of them are holistic in the sense they cover the whole case. So that what I would believe to be the case is that we cannot really begin to label ourselves as belonging to any of these, but we can usefully extract bits of them on occasions when they seem more useful than not in certain kinds of patients. And that's what comes out when the better candidates start to look at theories, and they very rarely say things like, now I'd like to give a dynamic formulation, for example, and if they do, it's usually awful. And it usually means that they've sort of that night read Fairbairn and Freud, and they whip out this sort of lump of words, and clearly haven't been using the ideas ever before. So it's sort of synthesized effort, and it's not overwhelming. I put this one last because, for one thing, I hate the word biopsychosocial, and it also leads into my next transparency. And this is an attempt which expresses the sort of notion of some attempt at integrating the various dimensions of a case. If I have the next transparency. This is a sort of device that some candidates and some consultants and some research workers use to try and balance things out. Most of you will be aware of that square. I gather that Bill McLeod tells me that the Canadians often add this bit to it, called protective factors. And indeed, several of the candidates are beginning to use that, and it does seem rather nice, actually, when you see it in written form. And I added this one myself because it seems to me logical that each of those things should have some kind of clinical implications. Now, that's a device. It's an aid to one's memory, but it isn't a very interesting conversation piece. If you decide that you're going to move across the squares or down them or whatever, you actually could use such a system to aid your memory, but if you're going to hand over a case or formulate a case, you're going to have to pick and choose. You can't escape that skill by using that kind of construction. If I could have the next one. Now, what are the actual obstructions to actually getting anywhere in terms of establishing a system? Well, the first one is, as I've already mentioned, that there are no holistic theories in the sense of theories of illness or theories of disease or health or coping or adjustment or whatever. We just don't have them. So it's very hard to have an integrated, uniform method of bringing something together that we can all agree upon. I think it's deniable that theories that attempt to tap the multidimensionality of illness are messy. The next thing that's messy is that somehow or other we keep ending up in a sort of middle ground between the biomedical, behaviour and public health sciences, and I guess that is inevitable, and it probably means that there's no possibility of us developing a language which will actually satisfy all those groups that we have to communicate with and be part of. There's also confusion about what is being treated, whether we're treating an illness or a disorder or a reaction or a cause or a process. And I think finally there is a great deal of confusion about the actual notion of cause of illness and its relationship to treatment. I think it probably is quite common for us to be actually treating the cause of a disorder, and the notion that that's why we learn about things in order to inform our treatment would need a lot of thinking through. There aren't many disorders in medicine where that's true. So if we go to the last transparency. I put these up by way of some answers. Whenever you get into that discussion about being in middle ground and so on, somebody will inevitably say, well, all you need to do is to speak in simple English and don't use too much jargon. And I mean, that's one of those statements you can't disagree with, but it does actually irritate me intensely. The reason it does is that I know damn well if I've got to talk to the immunologist, I have to use their language. And I reckon if I read an immunological journal article, it contains an immense wealth of jargon and words which don't communicate anything to anybody other than the in-group, and so on. So I actually am going to continue to use some of our words because I think they're quite good ones, and wait for them to learn how to use them. So I don't accept that solution in total. And you have the Engel solutions, which could be summarised, I think, as saying, well, if the other consultants don't understand us too well, the thing to do is to change the other consultants. And he has done that, I think, with substantial success, but the task is clearly limited. I've underlined the S because the other Engel solution is to give up and get hopeless. And we don't want to do that. I think we've heard a fair bit, really, about the teaching of psychiatry in medical schools, and there's no doubt that our ability to communicate with younger doctors, for example, is infinitely greater than with doctors who didn't have the kinds of educational experiences that our kids are having now. So there has been some progress on that end. The other thing is whether we can just keep searching for better words and better usages. And I'll just very briefly, finally, give you an example of a sort of idea that we're looking at to see if it improves our capacity to use ideas and to communicate. Could I have the first slide, please? What we are doing at Flinders at the moment is that we're looking a little bit at some of the words that are used in rehabilitation and seeing if they help us to be able to talk to physicians better in the areas that we're working in. I'm using here World Health Organization definitions of rehabilitation medicine, where they regard the word disorder as the primary pathological defect. They might also sometimes, or primary, that would include a primary learned defect. Impairment they regard as disruption of functional integrity, and I'll give you some examples of this in a moment. That actually describes, if you will, the disorder might be in a stroke, a lesion, the disruption of functional integrity, left-sided paralysis. The disability is the disruption of skills necessary for independent living, and the handicap is the environmental and social consequences of those things. So it divides up what you're treating, and we're wondering whether these words might help us to treat a little better. So we can have the next slide. I'm sure I can do it from here. This is what's meant by impairment. The loss or abnormality of a psychological, physical, anatomical, structural function. And the next slide. This is what's meant by disability. It results from impairment. It's defined by the restriction or loss of those activities normally considered to be essential for independent daily living. And the next slide. This is what's meant by handicap, just to remind you. It's the social, economic and environmental aspects of being disabled. I'm using these in a wider term than just the normal chronic disabled. And the next slide. You take a stroke, for example, the disorder is cerebrovascular disease, the impairment is left-sided hemiplegia, the disability would be being unable to walk, and the handicap would be being unable to work. Now we find that those kind of words and what they imply seem to have a certain generality about them. You can use them in all sorts of settings and people sort of understand a bit better what you mean. So if we take the next slide. In a panic attack, you might say that the impairment was some kind of pattern of dramatic over-arousal. The disability was an inability to selectively attend to a chosen task, excess distractibility, and a tendency to withdraw from activity, and the handicap is being unable to attend public places, and an increased need for reassurance. The next slide. This slide is actually Sandy McFarlane's slide. He actually went armed with his slide to the Neurosciences Club of Adelaide and talked about schizophrenia as a psychiatrist. Those of you who know the Neurosciences Centre in Flinders, it's full of people who are a little stunned if the nature of existence is longer than 8 amino acids. Octopeptides is where it stops. So to go and give this kind of talk in that setting is quite difficult sometimes. And this is the way he tried to transmit the information. And he took the view that maybe a dopamine transmission defect had something to do with the disorder, that was to seduce them. And then he took the view that the impairment was a disruption of ordered thinking, perception and affect, and he had a videotape there and he showed them that, and they said yes, they could see that was happening. And then disability, he talked to be the disruption of normal ability to react to and make sense of the environment appropriately according to past experience and current information. And the handicap was a withdrawal from relationships and inability to work and social alienation. And was then able to talk about, to these hardliners, I must confess actually one of them that was there was Laurie Giffen, who clearly isn't like that, but a lot of them were. He was able to talk to them along the lines of, well, what are you actually treating in this disorder? And to illustrate that an enormous amount of the effort of clinicians isn't up here. It's down there. And it struck us that those kinds of words might be one tiny useful little step forward in terms of developing some kind of better formulating skills of a kind that will be useful in a wider setting than just between psychiatric consultants. Thank you, Leslie.
Very useful model, but I wonder if you've got any comments on more acute issues and some generalisations that may see yourself, like just taking rehabilitation, for instance, and more chronic impairment, handicap, disability, and effect. What about things transient?
Well, we haven't really, because I mean I don't see any acute illnesses. I mean I only see people for an awfully long time, and that's true. I mean I haven't seen somebody with an acute anything for years. But I mean, and I imagine that if you did, well, it wouldn't be very useful, but by and large, I don't. It is useful. I mean, it's very useful looking at people with anorexia nervosa and people with agoraphobia and all those things.
I don't disagree with that to 100%.
I have no idea really how it would work. I mean, I imagine it's more limited, but, well, I mean, you know, it's a bit tricky. I don't think I would like to start talking to my patients about things like how handicapped they are. I mean, that's likely to be taken the wrong way, but it's actually quite useful language in a multidisciplinary team.
Ross, I wonder, would you like to say something about the relationship with this model, which I think is really very useful in what you said about formulation and the disability model, but in relation to something we haven't mentioned yet today, to our credit, and that's DSM-3, but it stands in the wings.
Well, I mean, I think, yes. When I think of DSM-3, I have a queasy feeling in my stomach. One of the things about the DSM-3 is that it does actually convey, just as a diagnosis, conveys an awful lot of information. What it does is like a mini formulation. It conveys a lot more information of a very useful kind, I think. And the other thing that's very useful about it is that actually sitting down and doing the hard work of deciding where they are on what, you learn a lot of things. So I would say that it does probably widen that orientating statement quite a bit, but it's hard going. I haven't got used to it, I must say.
Thank you very much, Mr. Lucy. And now the last speaker, of course, is Professor Valedictory, who's going to talk to us about the Diagnostic Utility Index.
Thank you, Leslie. I'd like to begin by thanking the organizers of this gathering in Professor Wallace Ironside's honor for inviting me to participate. It really is a privilege to be given the opportunity to express publicly my personal debt of gratitude to Wallace for providing, by his actions and by his words and by his writings, such a helpful and reassuring and encouraging model for myself, and I think for all those who wish to see psychiatry as an exemplar for medicine, of the way in which psychological and social and biological factors can be merged in the interests of effective clinical, academic and research objectives. Our theme today is appropriately education in psychological medicine, because Wallace has been so active in this area and has made such an important contribution to it. And what I want to do is to focus on a particular aspect. In fact, I want to focus on some of the factors that influence the decision-making process that occurs probably, as Ross and others have pointed out, occurs in the first few minutes. I, in fact, am probably talking about factors which operate on this process in the first few seconds. And in psychiatry, I would think in the first few milliseconds. Now, this can be demonstrated relatively easily. If you take a series of slides of facial expressions and you show them to medical students using a tachistoscope, which allows them to see the expression for only milliseconds, you will find that even with that exposure, there is general agreement amongst a group of, say, 10 or 20 as to what the facial expression is. In other words, if you put up a sad expression, you will find very few medical students who will say after a few milliseconds that the patient looked happy. They will often begin by saying, could we see a little bit more? Wasn't quite sure what that was. And you say, well, no, you can't see any more. Just take a guess. What do you think? And they'll say, well, we don't know. We'll say, well, more or less on 0 to 10, happiness to sadness. Most will say under 5, and most will score about the same, say about 2 or whatever. So there'll be general agreement. Nobody will say that it was a happy face. Now, to have made up one's mind about whether the person looks happy or sad in the first few milliseconds is obviously to have made some very important decisions, or to have begun to make some very important decisions about the patient. Now, what is it that influences this diagnostic set? This is obviously an important question, because one of the things we're always trying to do when we educate medical students and when we teach postgraduates is to somehow shape their diagnostic set, to make them more sensitive to certain symptoms and signs and certain diagnoses. And in the discussions, in the many discussions as to what it is that we should use to base our decisions on when we decide what to teach, people will say things such as, well, we should teach about what's common in the community that the students are going to work. They should know more than they know now about the common conditions. In other words, an epidemiological basis for deciding what we should teach. Now, that's obviously simplistic, and nobody would suggest that we make absolutely certain that whatever else the student is able to do by the time he qualifies, he can recognize the common cold, and that no patient should leave his surgery with that undiagnosed, no matter what else is wrong with the patient. Now, nobody would say that. So obviously we have other things in mind, and what we have in mind are things like how serious is the condition, how treatable is the condition, how expensive would it be to miss it, and so on. And these are things that are influencing the doctor. Now, it occurred to us some time ago that it would be interesting to see if we could quantify in some way what sort of value a doctor put on being able to make a certain diagnosis. Now, as you know, the best theoretical framework to turn to for looking at things like this is the area of signal detection theory. Now, signal detection theory arose, I suppose, mainly out of the experience with people like radar operators during the war. And of course it becomes extremely important now with when you have people watching radar screens and trying to decide whether what they see on the screen is a speck of dirt or whether it's a bomber coming towards their country with nuclear weapons or something of that sort. So it becomes rather important to try and get that right. And there obviously are two kinds of reaction to the situation, and one is the chap who, the moment he sees anything that looks like something unpleasant, presses the red button. And immediately $500,000 or $1 million or $2 million are spent in all sorts of things, getting a whole lot of people up in the air and shooting off in a variety of directions. Now, if he did that, his superiors might come around and say, now look here, you're doing a wonderful job of work, and we like the fact that you're so alert and patriotic, but would you mind not pressing the button quite so often? Just look a little bit more closely at those spots and try to be sure that it's not a bird. Now, he might say, that's all, I thought I was doing the right thing. That's all very well, but if that's how you feel about it, could you give me some idea of how excited you want me to get about these spots on the screen, especially when they're ambiguous? Now, it's perfectly all right if the spot he sees is enormous and it has a particular crest on it which he knows does not represent his own army, then it's straightforward. But if it's ambiguous and there are lots of other spots on the screen, it's difficult. So obviously, if there's a high noise-to-signal ratio, he has a problem. He has two problems, in fact. The one is his sensitivity to any signal at all, and the other is his bias. That is, the tendency he has to see it or not to see it. Now, we thought we would use some such basis for trying to establish what might be the, to use a jargon term, the payoff matrix of doctors. In other words, what's the sort of set of values they place, in particular, on getting it right and on getting it wrong. And so we set up a format which we call the Diagnostic Utility Index. And this is the way in which the questions are asked of the person filling in this index. As you can see, what we have essentially, and we haven't put them all in here, is a list of diseases chosen fairly randomly. I just took a list which, of which some were obviously serious and some obviously weren't as serious. But I'll show you the complete list in a moment. And along here we have the diagnostic decisions. Here we have the actual disease that's there in the patient. And obviously you can make two kinds of errors. You can say, these are the decisions. Now you can make two kinds of errors. You can say a condition is present when it's absent, or you can say that it's absent when it's present. Those are the two kinds of errors you can make. Now, a condition, of course, may be present, or the condition, we'll just stop at that point. If you say that the condition is present, when it is present, then that is a true hit. If you say the condition is absent, but it's present, that's a false miss. If you say the condition is present when it's absent, it's a false hit. And if you say it's absent when it is absent, that's a true miss. So at these two ends, you're doing the right thing, and here in the middle, you're making a mistake. And you're making two kinds of mistakes. Now, what we were asking people to do was to say how desirable or undesirable each outcome was. Was it highly desirable, a score of 4, or 3, or 2, or 1, highly undesirable? And we gave this list of diseases to 50 people, including medical students, pathologists, physicians, and so on. And we asked them to fill it in. Now, the way in which we scored it was as follows. You will appreciate that the counsel of perfection would be to score something like 4-1-1-4. In other words, both the true hit and the true miss are both highly desirable, score of 4. And the two mistakes are highly undesirable, a score of 1. That would be the counsel of perfection. So what we did was we gave each of those responses, I mean each array of responses, a score of 100, a perfectionism score. And we took 25 off each time they deviated from perfectionism. Now, I need hardly tell you that nobody deviated more than 4 points from perfectionism, because then they'd get a negative perfectionism score, and it's highly unlikely that anybody is going to say that getting the thing correct is undesirable. The only deviations you get is that instead of saying it's highly desirable, they say it's desirable. That's the kind of deviation you get. Now, the first interesting thing you find when you give this to a group of doctors or medical students, and they look at this thing and they can't quite work out what to do about it, but finally they sort out what they're supposed to do, and that's a very interesting process. But then somebody will always say, when you say desirable or undesirable, for whom do you mean? This is usually followed by a stunned silence. When it suddenly dawns on the others that somebody in the room, and they're probably thinking it too, feels that that is a question, whether it's desirable for the patient or the doctor. And then one gets into a very interesting discussion about that by itself, which you have to cut off in order to get on to the rest of the things. And also you've got to handle the situation, because I've almost seen somebody, I mean, everyone seemed to draw away from this one person who'd said that, as if he was some kind of a leper or pariah or something. But obviously he was expressing thoughts that were going through everybody's mind. It wasn't just his own. That's what we did. Now, the next transparency shows you a sort of popularity parade of diseases. But these diseases at the top achieve the highest perfectionism scores, and the diseases at the bottom achieve the lowest perfectionism scores. Now, the person who joined me in doing this research, when I suggested to him I was interested in this and wanted to do it, he was very excited about doing it because he is a clinical pathologist, very interested in decision making, because he was concerned that if a certain disease has a high perfectionism score from a particular doctor or from a lot of doctors, it's going to cost him and his organization a whole lot more, because they are going to investigate, using some quite expensive investigations, until they establish for certain whether it is there or not there. Now, so we got together on this thing, but of course I was particularly interested in where psychiatric conditions appeared. In a sense, they're markers, where they appeared on this parade, on this listing. And first of all, I think you'll see that the way in which they listed makes sense. And if you analyze it statistically, as we did, it becomes clear that people are taking into account the nature of the disease. They weren't simply filling the things in a random sort of way. So it makes sense that you get carcinoma of the colon and carcinoma of the breast and so on near the top, and you get nasal polyps, post-herpetic neuralgia, and eczema near the bottom. I didn't put in sciatica. I suppose that might become more important. But this just, as someone involved in the study of pain for a long time, I await with interest to see what will be the impact on research funding for chronic pain in the next year or so. Especially now that it's appreciated that the operation can have an effect on on elections, I was going to say, to use the Japanese pronunciation. Now you'll notice that anxiety neurosis is down here. Anxiety neurosis is down here. So I put in two psychoses, and I put in anxiety neurosis and senile dementia. And you'll notice that psychotic depression is up there. I mean, it's getting up there with the with things like glaucoma, thyrotoxicosis, and mitral stenosis, pernicious anemia. And that's very interesting that psychotic depression is up there. Whereas schizophrenia is down here, with still in respectable company, with myxedema and pneumonia. Well, I'm not so pleased about syringomyelia. And here we have senile dementia with rheumatoid arthritis, and we have anxiety neurosis down here. I think it's self-evident what's going on here up to a point, but let's take it a little further, analyze this just a little more to see whether the type of error is important. And what we now did was to do a factor analysis to see whether the various conditions grouped in some way according to the pattern of perfectionism. And factor one were these conditions which showed high perfectionism. But however, it was a true hit that was regarded as highly desirable, and a false miss was regarded as highly undesirable. In other words, conditions that they would hate to say were not there if they were there. And when you look at them, it's very interesting. I think it's reasonable to say that these are all, most of these are conditions where people would feel that there is a specific treatment which it is important to give as soon as possible. And therefore it's most interesting that psychotic depression is in there with them. So, which suggests that we've solved an interesting message about psychotic depression.
Do you reckon how the order and psychotic depression?
Yeah,
just
that's the order. Now, factor 2 is a relatively straightforward factor. It's simply low perfectionism in general. In other words, nobody gets that excited. They're not going to have sleepless nights worrying that tomorrow, when they see their patients, they will miss nasal polyps or post-herpetic neuralgia or anxiety neurosis. But this is where anxiety neurosis is, senile dementia. Easily we may ask ourselves the question, why is it that they're not worried about making these diagnoses to the same extent as they're worried about the others? And is it appropriate or not? And lastly, the third factor is high perfectionism, where a false hit is highly undesirable. So you see, these are conditions where they don't want to make the diagnosis. They don't want to say somebody's got that condition if they don't have that condition. Now, those were our findings, and incidentally, we can have the lights, thank you. I repeated this with a group of general practitioners, another group only of general practitioners, and what was intriguing was that the actual listing on the listing on the perfectionism list of those conditions was almost exactly the same as in the previous population. But then, of course, one might say it has a lot to do with the conditions chosen, so on and so forth. I understand that perfectly. Now, I think that there are a number of questions which arise from these findings, a number of possibilities. The first is, would it be interesting to try and find out what the payoff matrices were of a number of groups of people. For example, medical students emerging from different medical schools. Do the medical students who come out of Newcastle upon Hunter have different payoff matrices to medical students coming out of Sydney or Adelaide or Flinders or Western Australia or wherever? That would be interesting. The other thing that would be interesting would be, are the payoff matrices of students, do they change? Do the matrices change as a result of having done a term in psychiatry? Do the payoff matrices change with the age of doctors or with their specialities? Now, I think some of these things can be very important. For example, I think it's important for a doctor's perfectionistic attitude, the degree of perfectionism in relation to certain conditions, to alter as the years go by because of new developments in the treatment of that condition. I'm sure that there are those in this audience who have been out of touch with certain conditions or their treatments who still feel that it doesn't matter whether or not they diagnose a particular condition, or who don't want to make the diagnosis too readily because the treatment for it is horrendous. Whereas in fact the treatment may no longer be horrendous. The picture may have changed in the previous 5 or 10 years. I mean, this, I'm sure you will agree, does happen. And one retains stereotypes of certain conditions despite the fact that times have changed. Now, so that's one aspect of it. Just what is actually in the minds of doctors and medical students when they come to a patient. What have they been tuned to look for, and what have they been tuned not to look for quite so readily? I'm caricaturing it, of course, because one has more than a few minutes to talk to a patient, and one may be tuned to look for certain things at the beginning, but other things later on. The other question is, how did psychotic depression get up there with the big ones? And it would be difficult to avoid the conclusion that one of the reasons is that psychotic depression has been presented as a condition with an important organic input to its etiology and with certain quite clear-cut forms of treatment. I'm not saying this is right or this is wrong, but it's interesting that this is what makes the condition, if you like, a psychiatric condition par excellence, requiring a psychiatrist, a doctor to treat it. And of course, the dexamethasone suppression test now has a great deal to do also with this particular trend, because it suggests that not only is there a specific condition that you can treat and get a good response, but there's a specific test to find out if people have that specific condition. Now, there are many factors involved in the enthusiasm with which psychiatry, and certainly American psychiatry, has embraced things like DSM-3 and things like the DST and so on. And quite by chance, I came across an article which I commend to you, and which I think says something about this. The article is entitled "Somatic Theories of Mind and the Interests of Medicine in Britain between 1850 and 1879, and it appeared in Medical History, volume 26, that's this year, page 233. And the author is... I found this article very interesting, and it's possible you will too, but let me simply read a couple of sentences from the summary. He says, "The 1840s saw major changes in neuroscience, brought about especially by the general acceptance of reflex action as the mode of operation of most, if not all, nervous centers, and by the application of microscopic analysis and cell theory to the elucidation of the intimate structure of the nervous system. British medical psychologists stressed the importance of these developments to an understanding of insanity. However, their emphasis upon the novelty of their views obscured a considerable continuity with earlier physicalist etiologies for madness. In particular, inflammation, conceived as in essence a circulatory disorder, remained central to the theories of the somatic bases of mental disorder that were advanced. Although psychiatric writers maintained that such conceptions of the causes of madness were the only foundation for rational therapeutics, there was little connection between their espoused pathological views and their clinical practice. The principal use of such notions was polemical. Physicalism was deployed in the alienists' efforts to entrench and to enhance their professional prerogatives. In this regard also there was much continuity between the mid-Victorian period and the early decades of the 19th century. Thank you very much.
Anyone like to ask Professor Konofsky any points to clarify things?
I would like to support Professor Konofsky's suggestion that in different places people's perceptions about faith may be very different. There's a piece of work published many years ago by the Donwell, which showed that when people looked at acute abdominal pain, senior surgeons were much more frightened of missing a feasible diagnosis than were students and others. On the other hand, some work we've done here at Prince Henry's in the last few months, it was interesting that in fact it was the most junior students who seemed to be inclined that way, for instance, comparing epilepsy and pain. And so it's convincing to take it a little further and see if it's affected by education or many other factors. Unfortunately, also work we've done here suggests that whilst people may have fairly standard perceptions about utility indices and so on that we have outlined, it does not always affect their diagnostic activities and formulations in a regular way. There's obviously a great deal to learn here.
That's interesting.
Any further comments? Or? Well, if not, we've got 10 minutes extra for tea. Perhaps we should thank the four speakers before the party. Thank you very much.